Adelaide. And he's currently actually the mentor or supervisor of our staff, Dr. Andin, who is currently doing a postdoc in his hospital. And his research is focused on the atrial fibrillation, risk factor management, cardiac device, and postural orthostatic tachycardia syndrome. He has published more than 250 peer-reviewed journal articles, and his current age index is 56. Professor Lau, the session is yours.
Thank you. Good afternoon. I would like to thank the organizing committee for the invitation to speak in this plenary session. The title of my talk is Lifestyle and Risk Factor Modification for Reduction of Atrial Fibrillation. AF is the result of the complex interplay between triggers and substrate. Shown here in red are the major pathophysiological mechanisms underlying AF. This can be broadly classified into electrical remodeling, autonomic nerve remodeling, calcium handling abnormalities, and structural remodeling. This can be due to various cardiac risk factors contributing to this remodeling. The list shown on the right are the usual risk factors that we are aware of that could contribute to these changes. These mechanisms contribute to AF initiation and maintenance by means of atopic firing or a re-entry substrate. This slide demonstrates the abnormal atrial myocardium due to various AF risk factors, with the control examples shown in the top row and those with the disease that's been studied in the bottom row. As you can appreciate in this three-dimensional electroanatomical map, areas with low voltage are shown in red and those with normal voltage shown in blue and purple. Electrograms with double potentials and fractionated potential are shown in the blue and the pink dots. What you can appreciate here is in all these conditions, including aging, hypertension, heart failure, sleep apnea, even in lone atrial fibrillation and obesity, there was a unifying changes with increased atrial volume, changes in reduced atrial voltage, as well as reduced atrial conduction velocity and increased electrogram fractionation. Indeed, while it is initially thought that we could stop the AF remodeling process by AF ablation, however, this data from Dr. Kelman's lab shown that this is not the case. Shown here is an example of a 3D map on the left of a control patient and on the right of an AF patient. As you could appreciate, there is more area of lower voltage shown in red, orange, and yellow as compared to the control patients. Now, this patient had undergone AF ablation and was brought back for a repeat study 6 to 8 months later. What you could see here is, despite the absence of AF after ablation, there is progressive changes in the heart with a larger area of lower voltage as shown in the figure on the right. When the investigators look at the electrograms, they also found that follow-up after ablation, there was persistent increase in fractionated electrogram as shown here on the right, and also increase in activation time, demonstrating conduction abnormalities. This evidence suggests that the remodeling process is indeed progressive despite successful ablation. This slide demonstrates that cardiac risk factors are associated with increased incidence of AF, and this could explain the rising epidemic of atrial fibrillation. Shown here are the different components of the metabolic syndrome. As you can see, individuals with 5 of these components as compared to those with none has up to 4.4 times higher risk of developing atrial fibrillation. This slide demonstrates the results of a meta-analysis that we undertook several years ago. Shown here on the left is a list of risk factors that are associated with atrial fibrillation. As you can see, the relative risk ratio of developing atrial fibrillation is significantly increased with the exception of cigarette smoking. Several experimental studies over the years have aimed to understand the mechanisms underlying the role of risk factors in AF development. Shown here are cumulative examples of studies demonstrating increased atrial fibrosis, loss or lateralization of atrial connections that contribute to conduction slowing. This has been shown in diabetes, obesity, and hypertensive heart. In addition, animal studies examining sleep apnea has also shown a reduction in action potential duration as a potential mechanism towards atrial fibrillation. All these changes contribute to atrial dilatation over time and also diastolic dysfunction, leading to increased AF development. This slide demonstrates data from the sheep model of one kidney, one clamp hypertension that I undertook more than a decade ago. Shown here at the bottom are examples of atrial histology from baseline to 5 weeks of hypertension, 10 weeks, and 15 weeks. As you can appreciate, there's increasing percentage of atrial fibrosis shown on the picroserous rate stains here. Quantification of this data showed a progressive increase in fibrosis, and in conjunction with this, there was progressive conduction slowing, demonstrating the important contribution of hypertension in the atria over time. This slide demonstrates data from the sheep model of obesity. Shown here on the left is a control animal, and on your right, an obese animal. The 3D maps demonstrate a significant area of low voltage as shown here in the red, yellow, and green color, and also increased areas with electrogram fractionations as seen in the pink dots. When we took the histology out from this animal, we can see this new phenomenon of fatty infiltration from the epicardial layer into the endocardium, seen in the obese example, as opposed to the control animal, where there is a clear demarcation between the epicardial fat and the endocardium. This will contribute to more conduction abnormalities in the atria, therefore contributing to the AF substrate. In the next few slides, I would like to show you several clinical studies demonstrating the importance of risk factor management. This is a study comprising of 531 consecutive patients who underwent AF ablations with a mean follow-up of 19 months. Shown here are 3 separate groups of those without hypertension in blue, with hypertension that's controlled in red, and uncontrolled hypertension in green. What you can appreciate is those with uncontrolled hypertension has the highest risk of AF recurrence over time as compared to those with no hypertension or controlled hypertension. This slide demonstrates the importance of treating sleep apnea in patients with AF. It's a meta-analysis of more than 1,000 patients. Shown here are those who have not undergone PV isolation and those who have undergone ablation. In both groups, there was a significant benefits in CPAP use, with risk ratio of developing AF recurrence significantly reduced with CPAP use at 0.58. This slide demonstrates the benefits of aerobic interval training in reducing atrial fibrillation. 26 patients underwent the exercise intervention over a period of 12 weeks. This included 4 4-minute intervals at 85 to 95% of peak heart rate 3 times a week versus control with 25 patients. What you can see here that those who underwent the exercise intervention had a reduction in AF burden as shown on the loop recorder as compared to the control who had increase in AF burden. In addition to these changes in AF burden, those who underwent interval training also reported significant improvement in AF symptoms, the VO2 peak, as well as improved left atrial and ventricular function and echocardiography. This slide demonstrates the role of alcohol in atrial fibrillation. This was published in the New England Journal of Medicine in 2020 from Melbourne. the researchers randomized 140 patients with paroxysmal or persistent atrial fibrillation who were moderate alcohol drinkers. What you can see here is over a period of up to 180 days, those who abstain from alcohol had increased probability of no AF episodes as compared to those who did not abstain. Having shown you the role of risk factors in the AF substrate and how management of them may impact their AF clinically, I would like to turn your attention to the aggressive lifestyle and risk factor program we have undertaken in our center over the last decade. We will provide patients with weight management advice and exercise. This included targeting a final BMI of under 27 and increasing exercise of up to 250 minutes per week. We also enforce a home blood pressure diary to allow us to titrate the antihypertensive with a target of under 130 on 80. All patients were sent to undertake a sleep study, and if their AHI is above 15 or above 10 with resistant hypertension, they will be recommended to start CPAP therapy. We will often follow up with the CPAP therapy data to ensure that they're adequately managed. We also look at their fasting glucose and HbA1c and involve our endocrinology colleagues if required. Patients also have the other risk factors managed, including lipids. We will also advise them to stop smoking and abstain from alcohol consumption. This slide demonstrates our earliest data with regard to risk factor management. We randomized patients waiting for AF ablation in a one-to-one manner to controls versus intervention with the lifestyle and weight management. Shown here on the left, you can see that those who underwent intervention with lifestyle and risk factor management demonstrated significant reduction in their waist circumference as well as the body mass index. At up to 15 months of follow-up, you can see that those who underwent intervention had much reduced AF symptom burden as compared to controls. And on Holter monitoring, you can see that they have fewer number of AF episodes, and when they develop atrial fibrillation, they had shorter AF episodes. This slide demonstrates results from the ARREST-AF study. Shown here is the consort diagram. Patients who underwent their first AF ablation were invited to participate if they had BMI of more than 27 and at least one cardiac risk factors. Of these 165 patients, 61 accepted the aggressive risk factor management strategy and 88 refused. Therefore, they formed the control arm. At up to 2 years of follow-up, you can see that those who underwent risk factor management had significant higher AF-free survival as compared to the control. The factors that underlie the improved AF-free survival in the risk factor management group can be due to the significant improvement in weight, blood pressure control, glycemic control, the lipid profile, as well as better treated sleep apnea status. Additionally, in those who underwent risk factor management, we found reduction in left atrial volume and ventricular septal thickness on echocardiogram. Next, I would like to show you the results of the legacy study. This is a longer-term follow-up of up to 5 years, and this study nicely demonstrates the dose-dependent improvement in the maintenance of sinus rhythm. Shown here in orange are those with weight loss of more than 10%, in green between 3 and 9%, and in gray under 3% of weight gain. As you could appreciate, those with the highest amount of weight loss had the highest freedom from atrial fibrillation with ablation and or anti-arrhythmic drug use. This slide demonstrates the reason why risk factor management can result in AF reversal. Shown here is the results from the same patient of the electroanatomical map before risk factor management and 6 months after 10% of weight loss following risk factor management. You can see the dramatic improvement in the 3D electrical voltage from a lot of low voltage area in red and orange to a much healthier voltage after risk factor management. Indeed, we saw that apart from the voltage improvement, there was reduction in electrogram fractionation, improvement in atrial conduction, refractory period, as well as sinus node function. The improvement in cardiac structure was also noted with atrial size and ventricular septal thickness, and these patients also demonstrate reduced thrombogenic and inflammatory markers. This slide demonstrates results from the reverse AF study, clearly demonstrating the progression of AF as shown on your left and the reversal of AF as shown on your right. Those with the highest degree of weight loss, as shown in orange, had the least progression from paroxysmal to persistent atrial fibrillation, and the most reversal from persistent to paroxysmal or no atrial fibrillation. In conclusion, ladies and gentlemen, atrial fibrillation is a manifestation of underlying atrial myopathy. We have seen remodeling due to various risk factors from fibrosis, fatty infiltration, as well as gap junction remodeling. We also have seen how management of these risk factors will result in reduced AF burden. The risk factor management program that I've shown you has been shown to improve AF rhythm control underpinned by substrate reversal, and the AF risk factor management must be an essential component of AF care. This is now listed as a Class 1 recommendation in the 2019 AHA, ACC, and HRS guideline. Lastly, I would like to remind everybody that on top of the usual pillars of care in anticoagulation, rate control, and rhythm control, risk factor management is a very important fourth pillar of AF care. Thank you for your kind attention.
Thank you, Professor Lau. And although this is actually a plenary session, usually we have no Q&A, but since we still have some time, yeah, Professor Lau, will you accept some questions?
Absolutely.
Thank you. So there is one question in the Q&A from Professor Yoga. Will you ablate obese patients with very symptomatic AF who are not responded to medical therapy?
Yes, this is a tough question, and often we need to undertake a in-depth discussion with the patient. First of all, we would tell patients the need to work on weight loss and all the risk factors. For the highly symptomatic one, we'll offer one ablation and tell them that if they don't work on the risk factors, possibly if there's recurrences, will be unlikely to offer them the same treatment. Obviously, every time we do an ablation procedure in the obese individuals, we are going to be using more fluoroscopy. We're going to be subjecting patients to a higher risk of various possible complications. So we would really have a very clear discussion with them about this. And there are individuals who, after understanding this, will also go on to choose the pace and ablate strategy sometimes to avoid the risk of multiple procedures and choose a pacemaker and AV node ablation. So it is quite variable, but obviously we can't withhold treatment for the highly symptomatic, and you would do your best to treat the other risk factors as well, the blood pressure, the sleep apnea, the diabetes, to make sure that they're at the lowest risk of recurrence.
Thank you, Lau. Your data regarding the difference rate after the risk factor modification is really, very important to manage the patients. And you have shown that the hypertension and weight loss, hypertension management and weight loss management will give better substrate after the ablations follow-up. Actually, do you also, because in our session, this weekend cross in cardiology, 50% of our participants are general practitioners. I would like to emphasize regarding the risk factor management. If we have the patient with the paroxysmal AF, and then the center has no facility to do catheter ablations, do you think that the risk factor management will give benefit for the recurrency of the AF in addition to the antiarrhythmic drug only without ablations?
Yes, that is definitely the case. So we have often seen patients, for example, with nighttime AF onset, and invariably we find a high incidence of sleep apnea, for example. And after commencing the patient on CPAP and diagnosing the sleep apnea, then you can see a dramatic reduction in AF. So if patients have no access to ablation therapy to give them more immediate relief from the recurrent AF episodes, it is definitely worthwhile to go through all the risk factors, and treating them in conjunction with drugs will most of the time help, unless in those patients where there is significant remodeling in the heart, where there's lots of fibrosis, very dilated atria, then you'll find that you might be too late. So sometimes the remodeling is at the point of no return. So you can do your best with the combination of drugs and risk factor management, and hope that you can reduce the burden.
Okay, thank you. And lastly, before the second speaker, Professor Devak, in our hospital, and also I believe in Adelaide also, we can collaborate with our colleague from the cardiac prevention or rehabilitations to emphasize the risk factor modification for this AF patient. Do you have a special program in your hospital to not only for EPs, but also working together with other cardiologists in your hospital to design special program for this risk factor management?
No, at the moment, unfortunately, this is largely as an academic-driven program where we have our own specific AF nurse who has interest in looking after the risk factor management of patients with AF. The current funding model is restricted to post cardiac surgery, post PCI patient after the myocardial infarction event, and also for the heart failure program, where they have dedicated nurse that's already funded to help with rehab, specifically rehab, but not so much in risk factor modification. So it is then down to us as clinicians, and hopefully we have the resources with a nursing colleague to help us. But it is requiring additional time, more than your usual clinic appointment of 15-20 minutes to be able to deal with this, because by the time you explain to the patients about anticoagulation, about antiarrhythmics, about cardioversions and whatnot, the time is over. So we have a dedicated program with a separate nursing clinic where the patients will purely deal with all the risk factors on the slide that I show on the different components. And then a doctor will come in at the end to address any residual medical questions or to change prescription for the blood pressure care, or to make referrals to endocrinologists and so on. So without that dedicated program, I think it is very difficult to incorporate into your day-to-day practice.
Thank you, Professor Law. Again, we really appreciate for your contribution for this session, which enlighten us with these risk factor modifications, and also your last statement regarding collaboration with the nurse and the allied professional. I think we could apply that in our society and our university and hospital. Again, and thank you, Professor Law, and please send our warm regard to Dr. Andin.
I will. Thank you for the invitation, and it's my pleasure. Thank you very much. I wish you all the success in your meeting.
Thank you very much. Yeah.
Okay.
And we will move to the second speaker. Second speaker is Professor Delphak Osiandi from the Manchester University. He is actually a good friend of mine. We entered a different medical school in the same year. He graduated from Airlangga University, Universitas Airlangga Surabaya. And up to now, he is still consistent in his professional career as a cardiovascular physician scientist. And currently, his position is a reader in cardiovascular biology, Division of Cardiovascular Science, School of Medical Science, University of Manchester. and senior lecturer in that university. And he received so many awards in cardiovascular research from British Heart Foundations, European Society of Cardiology, Eumorphia Young Scientist, and Australian Society of Medical Research. His talk today regarding the hypertension and vaccine response, lesson learned in the pandemic era. Actually, this is interesting because he is also doing research together with, in collaboration with our colleague doctor in Indonesia. And I would like to invite Professor Delvak. Currently, sorry, his index is 26. Professor Delvak, time is yours.
Yeah, thank you, Dr. Suno. Good afternoon, everybody. Of course, I would like to thank the committee and also Dr. Suno for inviting me to this meeting. So, can I share my screen?
Yes, please.
Yeah. Can you see my screen?
Yes, we can see, Professor.
Right. Okay. Right. Okay. So today I would like to share some recent observation that which we did with our colleagues in Erlangga in Surabaya, Indonesia. As you know, I dedicated a bit of my time working as a young professor in Erlangga. So this is some of our study that's done during the pandemic era. So I would like to start by showing you some slide as an introduction that we all know that there are 4 factors that we know as part of the metabolic syndrome: obesity, diabetes mellitus, hypertension, and dyslipidemia, that together contribute strongly to the cardiovascular risk. But during the COVID pandemic, there's also observed or a phenomenon that's showing that at least 3 of those, obesity, diabetes mellitus, and hypertension, contribute to the COVID-19 severity and also mortality. So we can see there is some initial data. This is one of the example. I think this is from China, where the pandemic first started. Observation on around 1,500 patients clearly show that diabetes and hypertension, together with other factors, significantly contribute to the severity of COVID-19. Then this is another observation in the UK. It's later than that. It's observation on around 20,000 hospitalized patients with COVID-19, showing very clearly that along with age and sex, then you got diabetes and obesity. There's a significant increase in severity and mortality, and also chronic cardiac disease. And I'm sure hypertension is included in this. So then there's also a report. I think this is in the European Heart Journal, showing that individuals with hypertension, if not treated, have higher or lower survival or higher mortality here. And if you treat the blood pressure, the hypertension using antihypertension, there is an improvement. A patient with antihypertension have better survival. And basically in that report is also shown that there is no effects on the treatment with ACE inhibitor, because at that time there is some debate about the association with the ACE2 as a receptor of the SARS-CoV-2 virus. So later on, it's already been analyzed and discussed that it's possibly from these 3 factors of metabolic syndrome, like obesity, diabetes mellitus, and hypertension, there is a strong indication that there is a dysregulation of immune system that contribute to the COVID-19 risk. So I'm not going to discuss about this. What we want to know is, because the second phase of the pandemic, we are very lucky because we've got the vaccine that contributes significantly to the management and reduction of the COVID-19. So we want to know if obesity, diabetes mellitus, and hypertension have a dysregulation of immune system that affect severity the COVID. Then is there any effects on the response to vaccination? So we did a small study with colleagues in Dr. Stomo Hospital, Surabaya, when the first vaccination campaign and program started. I think it's around January 2021. We recruited around 100 healthcare workers in the Sutomo Hospital. And then, of course, during 2 or 3 months, they got a second dose, 2 doses of COVID-19 vaccine. And at that time, the only platform vaccine that used is the inactivated viral vaccine from CoronaVac or Sinovac. Then we follow up the antibody response up to 5 months. So we've got all the demographic characteristic, baseline data, and all clinical variables, and the result is as expected. We've got a really nice increase of the antibody IgG against SARS-CoV-2 RBD domain. But when we put all of the clinical variables and demographic characteristic and put the multivariate analysis, we found that blood pressure at the time of first vaccination contributes significantly to the level of antibody response. So surprisingly, we also look at smoking, history of diabetes, another CVD disease, and there are no significant association. So it's only blood pressure with around -11 coefficient. So roughly that means that if you have an increase 1 millimeter mercury blood pressure, then you will reduce 11 point of the unit of the antibody. So that's the rough estimation. But of course, the number is not very good because we only have 100 participants. So this is the more, when we look at the data more closely, we can see that on average, the level of IgG in participants with hypertension or blood pressure more than 140/90 is probably around 25% to 30% compared to those with normal blood pressure, which is quite striking. So we want to know whether this will affect the immunity against COVID-19 infection. So we try to do, at the end of the study, we try to do retrospective analysis, and we want to analyze in more participants. So we expand the study a bit, including several colleagues in the hospital, Bangkalan Hospital in Madura. So we've got in total 2,700 participants agreed to participate in this study. So we look retrospectively that most of them has got a full dose of COVID-19 vaccine the same time as before. And then during that time, we can record, go through the medical record in the hospital at the time after the vaccination and before the vaccination, the period of vaccination, about the incidence of COVID-19 infection. So we also have all the demographic characteristic and clinical variables, and basically this is what we've got, the epidemic curve. The blue line is the cumulative number of participants receiving the first dose of vaccine. As you can see here, start in January 2021, and the coverage is really good. So within 2 months, it's around 85 to 90% has got the second dose of vaccine. But interestingly, you can see here the red bar is the COVID-19 weekly cases amongst the participants, the 2,700 something participants. And you can see there are 3 peaks here. The first one is the original one. The second one, the second surge of COVID. before the vaccination. And interestingly, after the vaccination COVID, there is another big surge, and this could be due to several things. Maybe the vaccination is waning, or maybe the emergence of the Delta variants, because when we look at the sequence data from East Java, Indonesia, there are safe of the COVID virus variants between the first, which is dominated by the GH clade, and during the second surge, which is dominated by the Delta variants, or GK here. But then we would like to know, this is a really nice model, and we would like to know after the vaccination period, whether there is any influence or any effects of clinical variables involved in the incidence of breakthrough infection. So breakthrough infection is infections on those already fully vaccinated with COVID-19 vaccine. So the result is like this. So again, it's consistent with previous data that we only have hypertensions that significantly correlated with breakthrough infection. So others got some more than one odds ratio, like diabetes mellitus, but it's not statistically significant. So if we look at the odds ratio is around 1.3, I guess. So that means it's people with hypertension got about 30% more chance to get a breakthrough infection if they are fully vaccinated compared to those non-hypertensive participants that has got the full vaccination. So when we look at the data, it's like this. So in participants without hypertension, fully vaccinated, the breakthrough infection during the second surge is around 20%. But in participants with hypertension, it's 6% more. Or if we compare, it's 30% fold increase. So then we just think that it's probably there is some strong association between immune response, inflammation, and hypertension. And indeed, it's already known before, and this is a review a few years ago showing that yes, indeed, in people with chronic hypertension, there is a systemic inflammation, there is an increased CRP, IL-6, and TNF-alpha. But of course, it's still a big debate which one comes first. So it's the chicken and egg question. Is it inflammation first and then hypertension, or hypertension first and then it's systemic inflammations? And then it's also known that vascular inflammation, this is in the context of perivascular fat or perivascular adipose tissue. This is a tissue that surrounded the vascular tissue, that there is a different inflammatory or cell infiltration between subject with hypertension and normal. So that will cause the different arterial stiffness. Also, there is a study showing that inflammation also play a role in determining hypertension through the process in the kidney. Also, several aspects that's already known about T cell and B cell regulation, oxidative stress, and so on. So we would like to know very roughly what's happened in our cohort of participants. So I present again here the graph about the IgG level between individuals or participants with and without hypertension, and we try to look at the leukocytes profile. And as you can see here, there's no difference in the leukocyte, neutrophils, and monocytes count between individuals with and without hypertension before the start of the vaccination program. But we can see a reduction of lymphocytes count in individuals with hypertension. So whether this is contribute to the reduction in the immune response or IgG or antibody response against vaccination? We don't know, but there is some indication that there is a close relationship or association between chronic hypertension and some immune regulation. So what is the implication of this study? So before we think about it, I would like to remind everybody that the prevalence of hypertension in Indonesia is, well, as everywhere else, is quite high. So this is the report in 2017 by colleagues in Harapan Kita, led by Dr. Bambang Widiantoro. 34.5% of it on average individuals in Indonesia has got hypertension. But then we also did some survey in East Java, in Malang, as part of the Smart Health study in subjects, older subjects, 40 years or higher, and the prevalence of hypertension is more than 50%. So it's really high, and that's contribute highly in the risk to the CVD. So with that in mind, we can just probably do a little bit of mathematics probably. So if the antibody response against vaccination in people with hypertension is reduced by about 70-75%, so the level of antibody is only 25 to 30%, and then this will lead to the reduction in the protection after vaccination by 30%, because the incidence of breakthrough infection is up from 20 to 26. That means that's a reduction of protection of around 30%. That is our calculation. So if you have a population with around 34% prevalence of hypertension, then the vaccine effectiveness roughly might be reduced by 30% of the 34%. So this is of course debatable. So that means vaccine effectiveness will reduce by 10% every 30% prevalence of hypertension. If you have higher people with higher prevalence of hypertension, then the reduction may be higher. So this is debatable, but this is what we think is happening. So, for example, if we know that one vaccine have probably effectiveness to prevent one disease by around maybe 70%, but if you launch it in a population with 30% hypertension, then you have to calculate this possible reduction. So then we think, shall we control the blood pressure before the vaccination? So we didn't do that, but we tried to look at the data again. So basically we've got the data that some of the participants have known or have history of hypertension. And because most of them is healthcare workers, they are aware about it, and most of them taking the medication. So we found that if we put this as a variable, then we still have a significant association between history of hypertension and response to antibody response to the vaccine. Then some of the individuals with the history of hypertension, most of them taking medication, but some of them got the blood pressure controlled back before below 140/90, but some of them still have it still not controlled. So the blood pressure still above 140 or 90. And then we compare the antibody response between these two groups, and surprisingly, there is no difference in the antibody IgG level. So it's still around 25 to 30, about here, between the red one, the controlled hypertension, and the blue one. So it's still about quarter of the 100 something, the level that non-hypertensive individuals response to the vaccine. So this implies that this is not a good news, that controlling the hypertension may not significantly improve the response to the vaccine. The next question, what about response to
Delvac? 1 minute
time
left,
is up.
Prof. I'm sorry, yeah.
Okay. Yes, the response to other vaccine, because most of them use the inactivated virus. So we follow up the study because most of the people we've got the booster with messenger RNA vaccine. So as you can see here, the IgG level is increased. But then we compared again after the booster whether there is any difference between subject with hypertension, with no hypertension. It unfortunately is still the same. You can see here with after booster with mRNA vaccine, there is still a significant reduction of antibody response. So I would like to stop by several questions, not a conclusion, that we found the association between hypertension and response against COVID-19 vaccine. So the question is it only for COVID-19 vaccination? What about other vaccine? For example, hepatitis, dengue, HPV, and so on. Still, a lot of big questions regarding the mechanism. It's that involving the T lymphocyte regulation. And lastly, we now think that maybe hypertension is not just a disease of blood pressure and vascular resistance. It may also part of the bigger problem, and one of which is probably immune dysregulation. So hypertension may be a marker of other condition rather than a primary disease. That is a big question mark that's probably can be discussed later. So I would like to stop by thanking our colleagues, Dr. Gatot Sugiarto and Dr. Laksmi, who leads the study in Dr. Stama Hospital, Surabaya, and also our colleagues in Bangkalan Hospital and also Gajah Mada. Thank you very much for the attention. I hand it over to Dr. Sunu. Thank you.
Thank you, Professor Delvac. Very interesting finding, the phenomenon of hypertension and vaccination, COVID vaccinations. And as Professor Delvac have mentioned regarding the food for thought, yeah, there are many questions remain, but it is important that we found a phenomenon and it is published. So the next project will be to roll out or to investigate what is the mechanism and what is the effect of other vaccinations for the hypertension. And again, so I'm sorry, Professor Delvac, we have no more time for discussions, but I think the finding with Airlangga University as a collaboration with Manchester University is really interesting. And we will close these plenary sessions, and I would like again to express our appreciation to Professor Denis Lau and Professor Delvac Kusnandhi for contributing in this weekend course on cardiology. Thank you, and Assalamualaikum warahmatullahi wabarakatuh.
Assalamualaikum warahmatullahi wabarakatuh. Salam sejahtera untuk kita semua.
Good morning, ladies and gentlemen. A warm welcome to all of you.
Yang terhormat, Kepala Departemen Kardiologi dan Kedokteran Vaskular, Fakultas Kedokteran Universitas Indonesia, Dr. Renan Sukmawan, Sarjana Teknik PhD, Spesialis Jantung Pembuluh Darah Konsultan MAS.
The Honorable Head of Cardiology and Vascular Medicine Department, Faculty of Medicine, Universitas Indonesia, Renan Sukmawan, Cardiologist Consultant.
Yang terhormat, Ketua Yayasan Kardiovaskular Indonesia, Dr. Ade Median Ambari, Spesialis Jantung Pembuluh Darah Konsultan.
The Honorable Chairperson of Indonesian Cardiovascular Foundation, Ade Median Ambari, Cardiologist Consultant.
Yang terhormat, Ketua Acara WECOC 34 2022, Dr. Isman Firdaus, Spesialis Jantung dan Pembuluh Darah Konsultan.
The Honorable Congress Chair